We work with patients who have obstructive sleep apnea, and obstructive sleep apnea is the inability to breathe when you go to sleep. It is what it says on the tin. It's obstructive because your airway blocks off, and it occurs during sleep. And then the word apnea means cessation of airflow. We're interested in both how sleep apnea occurs, but also the consequences of that. So we're interested in what happens to the cardiovascular system and also memory and cognitive function with people who have difficulty in breathing during sleep.
First, I found that it was more difficult to concentrate on work, more difficult to make the effort to get in and out of work because I had a substantial commute to London and back. Secondly, my social life was shot to pieces in that all I wanted to do when I was at home was to sleep. And then I had unrefreshing sleep. I found I woke in the morning with usually a headache and feeling zombified, frankly. And thirdly, it affected my driving, as I found to my cost when I fell asleep on the M6, and was very lucky indeed to avoid a major or fatal accident.
If you're trying to get air into the lungs, how you do that is you create a negative pressure here in the lungs by increasing your rib cage, and that causes air to be drawn in through the airway. If this airway is then relaxed because you're asleep, what can happen is that as you suck down the negative pressure here, this part of the airway gets sucked closed. And particularly that can happen if you've got a narrow airway because your jaw here is a little bit more set back than it otherwise would be. And also if you've got a lot of fat tissue around the neck and around the airway, then that can also make the airway narrower. So that when you then try to breathe in, this narrow airway is more likely to collapse.
I had a sleep study which involved simply sleeping with an oximeter on your finger and some other recording kit overnight, and at the end of that they could tell that I had sleep apnea and that in fact I'd been waking several hundred times a night. I think my score was somewhere about 400, which meant that in fact I was getting no proper sleep at all.
So this is Jen, who's a medical student, and she's modelling our sleep equipment for us. And what she's got on here is she's got some electrodes on her head and in her hair, which are measuring her brain activity. And they will measure how many times she wakes up during the night and she arouses. She's also got a little cannula underneath her nose, which is measuring her airflow. And she's got two bands around her chest, which are measuring how much she breathes in and out. So if she stops breathing, these bands will keep moving because she'll be trying to breathe, but we'll find no airflow from this signal here. So this is Jen's activity. Here she is laying here. This is an infrared camera, and we can watch her during the night. And what we can see with her brain activity is that it's very low voltage and it's quite fast, and that shows us that she is awake during this period that we're recording her. Although funnily, I don't know if you can notice here that the wave signals are a little bit slower compared to here, and that's because she's starting to fall asleep at this point here. So she's obviously quite relaxed. So what I'm going to show you now is some data from a healthy volunteer who volunteered for one of our studies, and he turned out to have some irregularities in his breathing. He's got obstructive sleep apnea. At this point here you can see there's no airflow, but he's still trying to breathe. But because there's no airflow, his oxygen saturation's falling, and at this point here he wakes up again. And so he wakes up, and you can see there's noise on the microphone as he clears his airway and sort of goes and wakes up from sleep. And he gets some very nice big deep breaths here, which allow him to reoxygenate his blood. And there's a little bit of a lag on the oximeter, but you can see the oxygen rate going back up here to 97, whereas here it dropped down to 89 when he wasn't breathing. And also when he wakes up, you can see his heart rate gets faster. And if we had a measure of his blood pressure would go up at this point as well. Older people have less of an increase in blood pressure, and the increase in blood pressure is slightly slower. And the two things that we know about patients that have sleep apnea is, one, they have an increased cardiovascular risk because of these increases in blood pressure, and the other one is that they are sleepy because they have these arousals from sleep. But what we don't know is how aging influences that sleepiness and these increases in blood pressure. And sometimes older people don't necessarily complain of their sleepiness, maybe because they don't have to get up for work and they're able to have a little nap during the day. And also it may be that they have less of a cardiovascular risk because of this lower increase in blood pressure. But then the other side of that is that they might have a higher cardiovascular risk because they're older and they're more likely to have cardiovascular events. So normally we would treat sleep apnea with something called continuous positive airway pressure. In short term, hand term, it's called CPAP.
Simply put the mask in place, fit the headgear on, and this is all made of some sort of stretchy material, so it's not too bad. It doesn't have to be too tight. And then you switch the machine on, like so. Just take a minute or two to come up to pressure. It's now up to pressure fully.
What CPAP does is it blows air into the back of the throat here, so the patients sleep with a little mask on, and the airflow comes down the back of the throat and it splints the airway open and stops it collapsing when the patients breathe in.
I had my first night with a CPAP machine in a hospital bed where you tend not to sleep very well. I slept amazingly well, and in the morning I felt that everything was quite extraordinary. My body was recovering very quickly from years of sleep deprivation, and within 2 or 3 days I think I was totally back to normal. But it just took that time. Other people are not quite so lucky. They find it takes a week, 2 weeks, perhaps 4 weeks to get back in. And that's difficult if they're getting used to the machine, because they're not getting immediate benefit from the machine, and they're having to get used to what is quite an arduous therapy at the same time.
What we don't know is, with older people, is it worth them sleeping with this mask on their face? Do they get good symptom relief? And because of the number of older people that have sleep apnea, we also don't know from a health economic point of view, is it worth treating older people with sleep apnea? Do they, economically, does it make sense to alleviate their cardiovascular risk and help their quality of life? Or is it just providing extra burden on these older people? And so recently we've been funded by the National Institute of Health Research to carry out a multi-centre randomised trial looking at the treatment of sleep apnea in older people. This is the first multi-centre randomised trial that's ever been carried out in this country that's been funded by the National Institute of Health Research, and it's partnered between Imperial College, Edinburgh University and Oxford University. There are some key issues about this grant that are really important for me. One is that it's translational research. So we started off doing our physiological studies funded by the Wellcome Trust, and what we've been able to do is take the findings that we've got from those studies, and now we're actually in the position where we can translate that into something that may well make a difference with patient care. The other thing is that this is the first time that we've built up a sleep network in this country. So this is a big grant in terms of sleep research, and it's the first time that we've been able to do that in this country, which is very exciting for me.